be good to go.
Okay. So we will begin our meeting, and I'll just start the meeting with a statement relative to allowing remote participation. According to Chapter 107 of the Acts of 2022, known as an act relative to extending certain state of emergency accommodations, was passed by the General Court and signed into law by Acting Governor Karen Toledo on July 16, 2022. That legislative action revised Section 20 of Chapter 20 of the Acts of 2001, and in so doing, provided modifications to the Massachusetts Open Meeting Law, which allow for flexibility to hold remote-only and hybrid meetings while preserving public access and, where appropriate, public participation. Currently, that additional flexibility will expire on March 31, 2023, unless additional legislative action occurs. As part of today's hybrid meeting, all votes will occur via roll call. So we'll initiate the meeting. I'd like to welcome everyone who is here, and we'll proceed with our agenda. We have Tejal is here, Steve and I right now, and Kathleen Brown is coming. So we should be fine. Dr. Partridge is traveling and so cannot be here. The first item on the agenda is a review of the minutes from the June 23rd meeting. Does anyone have any comments they want to make on the minutes of the June 23rd meeting? So then I have a motion to approve those minutes.
So moved.
Okay, Steve moves, and I have a second.
Second.
Okay, Tejal seconds. Call for a vote by roll call. I will start with Tejal, who's on Zoom. So Tejal Gandhi,
Yes.
Stephen Epstein.
Yes.
Probably don't have time. We're just approving the
The
minutes.
minutes, that's fine.
Kathleen Brown. Yes, and Edward Cosgrove, yes. That's the minutes of that. And we're ready to discuss the issue of the rice farm with looking at the revocation of their permit. And so who would like to start? Tara, do you want to initiate that?
Sure, yeah. So today we're on the meeting agenda is to discuss the rice barn to permanently revoke the food establishment permit. And we do have Alex Rubin, who is Chris Heap's colleague. Chris Heap is off on vacation for the next couple of weeks, so she has agreed to sit in to answer any questions you may have. I know that Cheryl Sabaro was also going to join. I know she was in another meeting, but she was going to pop in virtually. So we'll keep an eye out for her if any guidance, extra guidance is needed from her, from the board. So,
Okay. So do you want to initiate where we are with this and bring us up to date?
sure. So as you recall, after our last Board of Health meeting, we had talked about giving Mr. Inta a 1-week extension to have all the items that have been witnessed so far to date remediated. So Mr. Inta had reached out to our inspectors to conduct that inspection on Friday, July 1st. We had Ali and Monica Pancari had conducted that inspection at 1:30 on Friday. And as you can see from the reports in the packet, there was a main report that Monica Pancari wrote out, and there was also a supplemental report that Ali did as well to kind of show more pictures, more details on things that were still observed on site. So as you can see, there were still violations noted. You know, one item that stands out that we were kind of disappointed to see were the pest droppings that were in the bar area. Again, this is the third time in a row now that we've witnessed pest evidence on site inside the establishment, which, and he had assured us on this last, at the last meeting, when he was telling the board that he was going to make sure that he kept on top of the cleaning and maintenance of his establishment. He has not been open to the public for many weeks now. So he has had plenty of time to clean and make sure that all the items have been addressed, but yet we're still seeing ongoing items. So it was very disappointing for our team to find those items still on site. So we're here today just to make sure that we can go forward with the revocation, because we all feel that we've had many chances to offer the resources to Charles, to have him and his staff do better food safety protocols on site. We have yet to see that. We all feel as a team that he will not be able to maintain a clean and sanitary food establishment. We're really adamant about this foodborne illness safety risk. We don't want the public to get sick. This is the bottom line. We know over and over again that we just keep seeing things on site that we should not be seeing at this point. So we ask the board to support us in that respect. So.
Okay. I'll take any input from the members of the board.
Well, in our last meeting, as you can see from the minutes, we said that if there should be any violations, we were old. At that point, we would revoke the permit for a period of 3 months. And I would propose that we carry through with that.
I agree. I feel like even him operating for a couple of weeks, we've had all this information. Sort of what did we know and when did we know it? And we've known it for a long time. So I just don't feel right now that this could be a safe operation.
So you're proposing a 3-month revocation
That's what we had agreed to.
as
at our
opposed
last
to a
meeting.
permanent revocation.
I don't know that you can even do a permanent one, but in any event, we had agreed, and Mr. Info was under the impression that we would be revoking it for 3 months. That is in our minutes.
Sure. We do have Ms. Rubin, who is counsel at Miaris in Harrington. Alex, do you mind weighing in on the permanent revocation or the time span revocation, and if it's possible for a permanent one?
Yeah, so the regulations specifically set out a revocation of 1 year, but it could be a different amount of time than 1 year if you put it in the revocation order. So if you wanted to revoke it for 3 months, you certainly could. You should just be aware that when you revoke, it essentially nullifies the permit. And so in order for him to reopen, he would need to start the permit process all over again.
Thank you.
Okay.
And Alex did note, because Tara and I did have a conversation with her earlier today, if a revocation order is approved by the board, Mr. Inta does have the opportunity to appeal that. And that appeal would come before the board at a meeting to be scheduled.
Okay. Anyone else with any comments to make? And Steve, do you want to make a motion?
So I would move at this time that we revoke the Rice Barnes permit to operate for a 3-month period.
Beginning on,
Beginning immediately, right?
okay. Well, 3 months from today.
A second.
And Kathleen seconds. Okay, I guess I'll put it up for a vote. Stephen?
Aye.
Kathleen?
Aye.
Dejal?
Aye.
Edward? Cosgrove? Aye.
Alex, we'll follow up tomorrow with you for help with the order letter or the revocation announcement, sorry. Thank you very much for coming. We appreciate it.
You're welcome.
Okay. Our next agenda item is to discuss revisions to Article 20, regulations to ensure the sanitary and safe operations of marijuana treatment centers. So I guess I will take any input on those. Who's their presentation?
So I believe Tiffany is waiting in the parking lot for the wood blocks that has your name on it. We forgot to bring them, so someone's going to deliver them for us. This is not a public hearing. The board has held multiple months of public hearings, so this is just a time for board deliberations and discussion about whether the board wants to make the amendments as proposed, make revisions to the amendments that were proposed. one of the things that the board had talked a little bit about, and I included in correspondence today, and then I also attached to the revised packet that was posted online, was some of the board members' thoughts about discounts. And Steve, I know you had a specific question, which you might be able to potentially ask a member of the audience here. I don't know if you want to phrase it, and then they can see if they are able to respond.
So the question is really the differential pricing between retail and medical. Because there's, I'm wondering whether or not what the real intent here on behalf of CIRA is to basically get a level playing field. That right now medical, for whatever reason, might be more expensive than retail, and that a so-called discount would actually just make medical the same as recreational. That's might be seen differently than if medical is less expensive than recreational or vice versa. So I just didn't know the answer to the question.
Anyone who wants?
So we know that there's a price for the actual product, and certainly medical is not taxed, but the commercial is taxed.
Correct.
Do you want to sort of add to that? Sorry.
I will. First of all, our operations manager was not available. I'm trying to see if she's available by Zoom and so on.
And we're early. So
What's that?
we're early in terms of time.
No, I
so,
understand. And so I do want to get the correct answer. I don't think there's a significant differential other than the retail, what we call the retail. But I will double check that as quickly as I can. Because the discounting is really about trying to assist those categories of medical patients who oftentimes, because of their medical condition, aren't necessarily in the position of being able to afford the discounting makes it available. And as we talked about before, all of the competitors in the business are in the space of doing AR and so on. So it's as much about us being able to compete, make it available to Needham residents and those in that proximity in other communities, so they'll come to our store and not be traveling further.
Sir, what is your
Well, I'm sorry, my name is John Jennings. I appeared with the board last time around, and I'm an attorney. I do regulatory work for Bob Smart, who may be available. I think he might be also trying to.
I mean, can I ask, it seems in some ways, you would want to encourage people to be treated through a process versus on their own, right? So sort of encouraging this route for people, particularly with health conditions, seems like an advantage to me.
Well, I have a comment I'd like, or something, a question I'd like to ask. Not opposed to necessarily the idea of a discount, but I don't understand why there would be gradations of discount depending upon the condition of the person. As I had read it originally, there were different percentages of discount depending on certain medical conditions. And I don't understand the logic behind that. It just seems to me that one discount like 30% or whatever off across the board just is more, it makes more sense.
And I would just add to that, I agree by medical condition didn't make any sense to me. I know it's sort of typical. Sometimes you may have senior discounts or veteran discounts that are given, but if it's going to be for medical conditions, it seemed to me that should be just across the board. But then that's all of the people that are coming to them essentially. So, I think that gets complicated for them, but I just didn't think it made sense to be picking and choosing medical conditions.
My name is Yvonne Packer. I'm the Sierra Naturals here. And I think a lot what you're thinking, you may be thinking about Frank's Friends in the AIDS where they had a specific program. So a lot of the discounts may be programmatic, not necessarily set for a particular ailment or a particular disease. So like Frank's Friend, it just happened to be an AIDS program. And so it's not like we're going to say cancer patients get a certain discount or.
Yeah, I think what she's referring to is the HIV AIDS discount was tied to a program that's used not just at Sierra at another store that around its medical, but has made arrangements with multiple stores
Okay.
across the area to offer a 50, I believe it's 50% discount. The others, we would be very comfortable. I think what happens is you look at a group like seniors and you try to make an occasional greater discount for seniors, you make an occasional greater discount for employees. And that is also about competitive in the market and what others are doing. And so trying to stay in that space. But we, you know, we're looking to offer discounts. And if the board was inclined to say we'd like them to be systemically the same, then I think we would be inclined to agree with that. But that's the reason that we're doing it. And honestly, we came in initially talking to the board about general discount. And we knew there was some inherent concern, historical concern about this. So we tried to look at, well, where are our key groups? Where are the ones we want to service the most? And it came down to employees, which is a benefit to employees and competitive to getting to higher end in the market. And it's offered at our other store as well. Seniors, we look at veterans, groups that we felt were reasonably trustworthy and the kind of groups that typically get benefit in the market. The AIDS and cancer, we thought were programs that typically, when or diseases that typically you can trust, these aren't people on the edge of whether they qualify for medical that truly have a condition that want this. We would certainly, you know, entertain the board entertaining a broader discount as we originally looking for. If it's discriminatory, and I use that in a small fashion, we attempt to define categories. We find difficult to.
Okay.
I believe, by the way, our ops manager may be trying to get in.
And say, I mean, I'm uncomfortable with, you know, calling some medical conditions fringe and other medical conditions mainstream. You know, for better or for worse, the Commonwealth has defined who gets medical card, who doesn't, and that's the definition. I'm also somewhat uncomfortable, honestly, with an employee discount, because that's not for medical purposes at all. And if it's, you know, if it's a benefit, the benefit could be offered would be an increase in their salary, which would provide for them to purchase marijuana that they wanted to get. So I mean, that would be another way to propose a benefit that would not involve a discount.
Well, I do want to clarify if it's not clear. This is a medical facility, and therefore the only employees that can take advantage of the discount are those with a card. This is
Okay, so it's not a generic.
It's not
Okay.
generic to every employee.
Okay.
It has to that. when
So
we
they
say
qualify
employee,
as a medical
That's
patient.
correct. They're employees who have a medical.
As long as they're a patient, they're a
Yes.
patient.
Yes, that
Okay.
they are.
Of course.
And that would be the same across any medical facility.
We do have a couple of folks who are attendees. I do recognize Bob Smart is there.
Bob Smart and then Gretchen.
So the board is under no obligation to hear from additional people, but if it has additional questions and it wants to ask it, we could promote them to panelists. That would be helpful.
Well, the question is still outstanding, right? Is what's the differential in pricing or cost between medical and the recreational facility?
Take a moment.
Hello, this is Attorney Robert Smart. I don't know if you can hear me.
Yes, we can, Mr. Smart.
Oh, you can, okay.
We can hear you.
I apparently got in. I thought you weren't starting until 5:25, so I just joined in a couple of minutes ago. And I heard John Fernandez's voice, so I don't know exactly what he's said, and I certainly don't want to repeat anything that he said. Are you looking for anything from me or from us in particular by way of information at this point?
I think Dr. Epstein's question, and Mr. Fernandez indicated maybe Gretchen McCarthy would be the best person best positioned to answer it. And Steve,
Yes,
that
I'm
was-
on.
Great. So I think Dr. Epstein's question was, if there is a product for sale at both the recreational and a medical store, what is sort of the price of the product, and is there a difference? And is the only difference between the two prices the cost of taxes on recreational, or is there some other factor that contributes to a price difference?
Yeah, and you do see that around the market, but for our specific locations, there's really no variance in the pricing. It really does come down to the tax. So a medical patient doesn't pay a tax, and then the adult use consumer pays the 20% tax. I have seen, of course, over the market that if you're in different regions, sometimes the pricing can be a little bit different based on where you're located. But our stores are pretty close together that, pricing is pretty similar at this point in time.
So that would be that there might be a different price in the Berkshires or something than,
Right, like if you have a store down the Cape and then you have one on the western part of the state, sometimes you do see a little varying pricing from, our competitors, but that is not the position that we have taken right now. And of course, we just opened two. They're very recent. I can't say that won't change down the line, but right now, all of our pricing is the same. There are, of course, different products on the medical side because you can have a higher dose product versus the adult use side where you have a certain limit in the milligrams per dose. So you will see some variance there. But it's just because we can sell certain products in medical that you cannot in the adult use market. So obviously that would be a little bit of a variance, but really it comes down to the taxes.
So there's still an incentive for somebody to have a medical card and go to a medical facility because essentially you're getting a 20% discount, if you will, on the same product, really just because you're saving on the state tax, correct?
Yeah, exactly.
and not to introduce things that are generally sort of beyond the board's immediate permit, but as I understand it, Sierra has petitioned the planning board for a change in the business model such that medical patients with a valid medical card could go in anytime during operating hours. They wouldn't have to specifically schedule an appointment. Is that correct?
That is one of the things that we're seeking, yes.
The petition has not yet been filed.
Okay.
We're pulling together the necessary documentation.
But my understanding is that that is the purview of the planning board, not the board of health.
So right now, the permit for the business from the planning board, the special permit requires a specific number of, essentially this is going to come down to parking spots, I think, for the planning board.
Which the planning board has made a decision that the number of parking spaces that we have will be adequate for lifting appointment only, and we provided them with data on traffic study and use of parking, observation of use of parking.
And part of the idea is, at least from Sierra's perspective, right, is that if the marijuana treatment center is viewed as a pharmacy, a la CVS or Walgreens, the person doesn't have to schedule an appointment to come and pick up their prescription medication, provided it's ready from the pharmacist. They can go at any time for their convenience.
Yeah, it is normalized. There was a period of time when these first opened where there were a limited number of stores, and therefore people from a longer distance were coming to a store and queuing. And I think the most provocative example is Brooklyn and the Netter store. You can go there now and see that. And now that the stores are more common, you find people neighborhood shopping. And so the numbers are actually down at the store as a consequence of that. And there's a more sophisticated approach to getting people in. People are doing online ordering and doing pickup. And there's an ability to schedule people sort of without appointment only, but we know who's coming through. There would be no queuing, no backup. And that's what
All right. Does anyone else, any questions or observations?
I mean, my sense is that the real issue here is the current means of means testing is kind of the real issue. You know, I understand you want to offer, you know, Sarah wants to offer a discount to those who are having difficulty affording their medications, you know, senior citizens and the like. There is currently a means test in place. It sounds like that means test may be onerous, but if that is onerous, I think the issue has to go to the state because they're the ones who make that rec, not us. I don't know if we can supersede the state in that area.
I think we
I
could
think it
make
would
it
be
more
worth it.
rigorous, but not less.
Clarification, but in general, public health law allows locals to have more stringent.
More
regulations.
stringent, not less stringent, right? And here we're asking for something less stringent.
So we could certainly, we don't have a legal answer from either town council or from Mass Association of Health Boards, but we could ask that question. In general, the general answer is what you said, which is that local public health can often be more strict, but not less strict.
If I can clarify, I understand it's up to you to speak, but we're not asking you to try and change that. We realize that it's set by law, but that doesn't obviate the ability to offer discounts under the CCC regs. They just don't get into the means testing.
Right, it's a matter of, you know, it's really a matter of why you offering a discount, right? If you're offering it because there are certain medical patients who need it more than other medical patients, this board so far has been, you know, I think I'm speaking for everybody who's spoken so far, has said that we're not going to differentiate based on medical, either you're medical or you're not, right? So the other differentiator was, well, look, there are certain groups of people who have trouble getting their medication. That's means testing. There is a process for means testing at the state level already. So if that's the other, then you're asking us to change the means testing, which we don't have jurisdiction over. You know, and if we did, it would only be to make it stricter. Now, we might, you know, this board may decide that we want to, you know, support an effort from SIRA and others to change the means testing. That, you know, something, maybe this is too strict and, you know, we should petition the state legislature to make a change so that it's not as bad. But you know, if that's the reason for discounting, it's means testing, that's how I'm seeing at least the route to go. Because I'm not sure that we're going to be able to come up with some sort of means test that's going to, you know, be less stringent than what they have currently.
Well, I think this conflating respectfully that means testing is setting a minimum by which you shall allow discounting versus there's the lack of a prohibition on discounting generally, except for this board putting that discount barrier in place. And so, yes, one of our requests is to lift that because the means testing is very low and you can't capture the audience. Other factor, or at least one of the other factors, is we are in a competitive market and we're the only one in that market that can't offer discounts, and it has nothing to do with means testing. Control Commission that has strictly to do with the regulation of this board that other boards of health and other towns have instituted.
So I think that's an
It's just
interesting
about
point.
cost, right? Yeah. it's-
One of the reasons the board had originally adopted the no discount prohibition is large part because our marijuana regulations were modeled off of some of the experiences we had learned during tobacco. And it's a well-established feature of tobacco control that discounts promote use. I think it potentially is not a like-to-like comparison. It was the best information we had at the time, but it was not a like comparison to say that youth use of tobacco products, which have no medical benefit, is comparable to what the Commonwealth views as a medical product in medical marijuana. So it's up to the board to decide whether the fact that we originally kept that was the right approach, whether it wants to continue it. But that was the rationale for why it was originally included in the regulation.
Yeah. Which makes sense. So I mean, one of the things would be, we probably want to get some more information from some of those other boards, you know, probably in our surrounding communities, right? Wellesley, Westwood, Norwood, Dedham and the like, and kind of see, you know, what their experience has been. But then, you know, if we said, all right, so let's entertain the idea that there would be a discount, you know, how does this actually work? I mean, is this going to be a time limited thing? You know, this month it's less expensive, and how does that not drive people to purchase during that time? And is that going to change consumption as opposed to having just a permanent, you know, change in the price, as opposed to calling it a discount? Just lower the price and then you have your discount, you know, at all times. That won't drive people to come, but it will allow Sara to be competitive in the marketplace.
So right now, they're just talking it out loud. Right now, the thought is potentially if there's a discount during the month of July, I might buy more medicine in the month of July. And there are two possible outcomes for that. And therefore, then I buy less medicine in August because I bought more in July and I spread it out over whatever the right appropriate period is. Or one of the concerns you have is potentially I don't follow the recommendation of the physician and I take more medicine than is recommended.
You're buying for somewhere else.
You know, honestly, I don't know what the shelf life is of any of this. Speaking of which, right? So, I mean, if you bought something in July, could you use it in August? I'm guessing that the shelf life is certainly would allow for that, but I don't know the answer to that.
Yeah.
It's typically 1 year.
1 year, yeah. So that's a non-issue then. Okay.
And just to also say that, you know, medical patients do have a certain allotment and that is tracked, and obviously we would never dispense over the patient's allotment. So that is controlled. I know I heard that where you might take more than your doctor recommends, but that's all tracked. And, you know, we make sure we never send, that's against the law to send someone over their allotment.
In other words, it's like a prescription in a pharmacy. You have 3 refills, and unless the physician re-prescribes it, that's the end of it.
Yeah, so you get a certain allotment and it's a, you know, rolling time frame. So our system, there's a state tracking system where we check every time someone comes in, and it will show you what their allotment is, and it will not allow you to dispense over that. So that part is covered through the state tracking system.
On the state tracking system, the products that are sold in the medical facility are also the same product is sold in recreational, so they could still go to another place and buy it recreationally, or that's all one system that's tracked.
The medical side of the business has a state tracking system, and so does the adult use side of the system. It's metric, and then it's obviously the state side. So it's tracked seed to sale as well as allotments on
So I
both
guess,
sides.
are those systems linked?
Yeah.
So, you know, a medical patient comes in, you can see, wait a minute, you've been buying quite a bit of recreational, well over your, you know, medical allotment. Or maybe
No,
people-
you do not. That is not linked. No.
Not linked, okay, so that
So
is a
you wouldn't
possibility,
know.
right? You would not know.
No, you would not know, as the medical system is separate from the adult use, although both do have metric, which is just the state tracking system. So you can track movement of the product between retailers and wholesalers and things like that. But it does report to both of these systems in real time. So the state has access to everything.
So I'm not comfortable always being necessarily an advocate for the changes Sierra is looking for, but if we're trying to set up a like and like comparison with how a resident of Needham might purchase prescription medications, that is strictly controlled. Whether they buy some additional Claritin doesn't, you know, the state has made the determination that that over-the-counter drug doesn't impact their use of, or the prescribed amount of their other medication.
This isn't exactly over the counter.
I think that's a fair comparison, although, yeah, recreational is not the same as over the counter, but
Right.
it's probably the closest we have.
That's a question, right? Because if it's really over the counter, you don't need a medical card.
Yeah.
You just go in. I mean, the recreational side is the recreational side. The medical side isn't that way, though.
But sorry, I was saying the recreational is the equivalent of over the counter.
Agreed.
Medical is the medical, and that's sort of a like and like comparison between a physician recommendation for marijuana versus a prescription for. The question is, so like, now there is no control in place for me to can't buy more over-the-counter allergy medicine if I've already fulfilled my
Right.
medical prescription for.
I know this is,
Trazodone.
right, I never liked the system to begin with, but this is where it gets tricky, right? Because, let's say it is a controlled, let's say it's a controlled substance, right? That is, by, behind the counter.
Yeah.
So if you said it was oxycodone, for instance, and, you need a prescription for it and you have an allotment, but, oh, guess what? You're getting it somewhere else too, we'd have a real problem with that. If it were Claritin, we're not going to have a problem with that. If it were Viagra, there are some people who can get that, via mail order or what have you, right? In addition to what they're getting, through their insurer. So there are all sorts of models in play here.
Mhm.
And it really kind of depends on.
I
how
guess
you
I'm
do
thinking
this.
of like cough syrup has alcohol in it sometimes, right? So you can get something like that and yet you can still go buy alcohol.
Right, or dextromethorphan, and I see plenty of patients who Robotrip, so,
Well, yeah.
we overdose on it.
So I guess I come back to, we are an island of regulation compared to communities around us, and people can just go up the border. I mean, it's almost walking distance practically from.
And certainly the
Facility.
board has never had a problem having stricter regulations. I think the question maybe is this regulation serving a compelling public health purpose?
But I would like to see what our surrounding towns actually are doing.
Sure. It's a few years old, so we'll have to check. The last time I did go into this, a lot of communities hadn't developed their own local marijuana regulations. But we'll survey.
I can tell you Newton does not. I did try to look at those when we started this process. They don't have their own regulations.
Try to think about Wellesley and Brookline.
Westwood, Dedham.
Yep.
Yeah, native.
Are there any other comments, questions for anyone at this point? So at this point, we'll wait for information that you gather, and we'll discuss particularly this discount issue at our next meeting, and maybe vote, maybe not vote on changing the regulation. Okay, so we'll leave it at that.
Thank you.
Okay, thank you.
Appreciate your dialogue.
In my view has somewhat changed. I'm not opposed to discounts as much anymore. As long as the discounts are evenly applied, I guess you say. That would be my position at this point. Okay, so we are at almost 5:45. So we're up to the COVID-19 response phase 2 after action report.
Sure. And so this was a long report that was included for the board's
Yes.
information. We've now documented the first phase of our COVID response. This is our second phase. I think we're trying to figure out, given the amount of time and effort, want to document the third phase, which would be the year that's sort of starting right now. There's fairly significant, and it's at the end, but an improvement plan. It's something we're going to try to devote a lot of effort to. The public health staff, especially Tiffany and Tyler, Michael from the emergency management team. There's a couple of things to improve, more than a couple. I feel that we have done a pretty good job. We feel it's important to have an opportunity to present this to the board and then to make it public on the website for residents of the town to see sort of how we're assessing the response of the town's departments. We did try to include, in some cases, the work that has gone on with the schools and how we've shared information and coordinated with them. That wasn't a large portion of the first COVID after action report. So we did try to emphasize that in this report. But I'm happy sort of to take any questions from the board or have any discussion.
Anybody have any comments? I mean, my overall comment was that I was very impressed by what I read in this report. And I think that our response was better than, than other boards or other health departments that I've heard of. And I think that we have a right to be proud of what was done in town, and everybody needs to be commended for the work they did. And I am glad that it's documented.
I would agree with that. And I was actually really impressed with the comprehensiveness of this after action report. It's often the time and effort isn't put into this kind of debriefing after this kind of event that we've had. And I just think it's really great work to spend the time to think about that, what you did well, which was a lot of stuff, and what could be better. So really kudos to the team for this.
And I think it enters this into the historical record. So when some other pandemic arises, and it's going to happen sooner or later, there's something to go back and look at.
Yes.
You know, we're all talking about, people saying, oh, well, what did they do in 1918? Well, that's a long time ago. It's not that well documented. And so now here's something good to look at. So it's solid. I think that's important.
One of the major areas for improvement identified was the challenges that resulted from differences in state guidance, specifically between the Department of Public Health and the Department of Elementary and Secondary Education, or sort of hastily issued or not issued in advance guidance from the state. Guidance that was released at 9 a.m. and went into effect at 9 a.m. I think one of our sort of to-dos from this is to figure out a way to share in a constructive manner with the state the challenges that some of their decisions or their lack of coordination across agencies made on the local level.
That's a good point. Right. Because
And that's,
decisions were made like, okay, right away, you're going to do this.
yeah, that's one thing I saw really lacking in the report. I mean, it's very good at documenting what we did, but we were hampered tremendously by the state. And that needs to be a part of this as well, because, part of what this might entail is advocating at the state level to follow your local public response plans or don't have them. We spent a lot of time and effort preparing for this. We were ready for this. We spent a lot of money getting a freezer that went wasted because they wouldn't give us vaccine when it was available. Instead, all of it going to, the mega centers at Gillette, which meant that our population that was frail and elderly or just doesn't have transportation couldn't get the vaccine because we couldn't give it to them. And that was a major failure of this, and that needs to be noted.
That's true. I was very disappointed at that particular decision made at the state level. I mean, we were all geared up for local vaccine administration, and then they just cut our legs out.
I think from their perspective, and I certainly don't want to defend it, I think they felt that there was such a difference and disparity in local public health capabilities that giving it to every community was not an option. And they felt like giving it to some communities that could sort of stand on their own 2 feet also wasn't an option. Now, obviously, I disagree with that decision, but that was the state's rationale. I think part of that gets into what have you done to strengthen local public health infrastructure? What is the state doing to follow up on the special commission report and its recommendations? So there is a minimum level of capacity in all communities across the Commonwealth.
Right, but for instance, this department's going after, official, accreditation. Now, maybe there's something that comes out of this that, if you have a locality that has official accreditation, you have got the vaccine. And that's the distinguishing characteristic. But the fact is that, yes, we have a much stronger department here than many communities do. We were ready for vaccine. And frankly, I think we should have gotten it. I understand, the state felt differently. But I think that was an error and that harmed our population, and we shouldn't be bashful about saying that.
No, we should. And the vaccine we did receive, we used effectively and quickly. And that's a tribute to Tiffany and Hannah and Mary and the medical reserve staff and volunteers. But yes, we would have liked them to be a lot busier than they were, and they were quite busy.
Yeah.
Yeah, I would say the medical reserve corps is, you just had these people who just hundreds, right? Over 100 people wanted to do it. And we holding on to. So it's a shame we'll lose them, right, through time, we probably already are. So that's unfortunate because we have a lot of skills and those were really effective efforts. And even if you only vaccinated a few hundred, it was a community effort, I thought. It's meaningful to people. The other things I would say is that the timing on this ends last June. It's been a pretty different story the last year. And many of these go back and look at some of the interventions and the things we were enforcing. I'd like to be digging a little bit more into what makes sense, would we be so physical distancing and all these things that probably make no difference in respiratory infections. So things like that, I think and the social implications of some of these policies. We were all, at the state, everyone was focused on as few cases as possible, but we're looking at the ramifications of that now between drug and alcohol use and all the other problems that we have in our community. So I think a bigger picture approach too is.
One other kind of thing I was wondering, what's your plan? How are you planning on using this?
So I think we want to publicize it and make it available for residents who are interested in looking at it. I will say that the first COVID after action report, things from the improvement plan that got done were almost incidental. We didn't have a time to convene, a group that met every Friday to try to advance the improvement plans. This year, we're going to make an effort to do that. So that, hopefully when we have a future, we can say, hey, we checked off 7 out of 10 boxes and we're still working on 3 more. That's part of the reason. It does help in terms of funding, showing that the town uses the instant command system, showing that the town documents, include, the FEMA capabilities, the CDC and ASPR capabilities, that we're sort of tracking how we respond in that way. That does help us when we're applying for grant funding. It takes the place sometimes of doing an exercise by showing that our real world response is documented.
Okay. This might strengthen our position when we do come up for actually apply for accreditation and do it.
Yes.
That would be good. Okay. Any other comments? Pretty much on target. We'll move on to our staff reports. So the first person is Michael Litvin.
Good evening, everyone. So in June, the local emergency planning committee hosted a tabletop exercise using a hazardous materials emergency preparedness grant. This exercise involved a release of or a mixture of 2 chemicals that resulted in a chlorine release at the RTS, resulting in a mass casualty event. This exercise was really well done and well received, I think. And there's a lot of good communication that came out of it. The after action report is still in draft right now, but I think we aimed for a more realistic scenario as opposed to some of the hazmat exercises that have been done in the past, where a train hits a truck and the whole world ends. So this exercise was really good because it was able to identify a lot of gaps at the RTS that they're going to pursue with getting a safety consultant on their end. And there's a lot of good coordination between the fire department and BID Needham about who does decon when and where. So I was really happy with the outcome of that exercise. We also had a lot of meetings with FEMA regarding the public assistance reimbursement for the January blizzard. They will be in Needham on August 2nd, and they'll take copies of all the documentation that they need, and that should hopefully end the reimbursement process for that storm. And then the other big thing we started in June was our active shooter training and exercise schedule, We're trying to get space in schools right now to actually exercise the police and fire, but the training is all ready to go for them. And the idea from Tim and I's perspective is that going forward, we'll sort of build building blocks on our exercises, eventually doing a large scale exercise at Babson and Olin. The Babson police have already shown interest, so we're hoping to be able to get, Wellesley Police and Fire involved, as well as Needham Police and Fire, so we can see how that interagency operations would work. Because if anything were to happen, obviously Needham would not be responding in a bubble. But our first step of this process is to this summer get the new police and firefighters who have not yet done the active shooter training or worn the ballistic gear into their gear and get comfortable with that gear. Are there any questions for me?
No, I have none. Anybody?
One thing I would just add is we are in the beginning stages of that. It's possible that that would be a very expensive exercise if you're talking about multiple municipal departments, probably state police. When you're talking about an active shooter, there's a lot of work to make sure that no firearms have live ammunition. There's a lot of work to have expert evaluators assess tactics. That's something we will probably go to the finance committee and town meeting, not this year, but in a future year, and say, we need a dedicated source of money to carry this from the building blocks Michael talked about to the end product. I think we have a pretty good track record of using our emergency management funds and getting in more grants, but that's something that we'll need the board support on.
Yes, definitely. I think it's
Thanks,
becoming
Michael.
increasingly obvious that that's important.
Mhm.
Okay, thank you.
Thank you.
Okay, next report is on the traveling meals program from Rebecca.
So we kind of transitioned from our regular 6 volunteers per day delivery schedule into our summer driver delivery schedule of just 2 drivers per day. That's going really well. We delivered 843 meals for the month of June to 47 consumers. 39 were Springwell, 8 are private pay. We had 4 new clients, 3 of those were Springwell, 1 of those was private. At data from fiscal year 2021 versus 2022, up 1%. Meals delivered were up 1%. We only had 2 911 calls. One of the calls was when I actually called 911. They had already responded to her and she was already in the ER. The second call, she was just sleeping, didn't get an answer. Yeah, it was a good one. Any questions?
Don't have none.
Thank you.
Everything is working well. Thank you very much. Great job.
Thank you.
Accreditation team, Lynn?
So the bulk of our effort in June and in July has been going toward the senior assessment that we're doing. The survey has been released. We are already getting back responses, and we got back 2 written responses in Mandarin, which I'm very excited about. But we're also getting online responses. The other thing that we've been doing on that is conducting interviews, key informant interviews, and focus groups. So we're going all out on this right now. At the same time, I'm very happy to say that I have been very concerned all along about the burden that accreditation can put on the staff. Everybody is already so busy, and accreditation is an enormous amount of work. But we've started to do that by initiating our steering committee and talking about how to involve more staff in the process. So, all of us.
Okay.
I think that's.
Any questions for Lynn? Okay, thank you very much. it's an important project, and I'm glad it's going forward. Okay, environmental health. Harry, you want to?
Sure. So to start off, I'll just go through my training with you. Isn't it? So last month, I was able to attend the National Environmental Health Association virtual educational conference. It was held in Spokane, Washington, but they did have the virtual option this year, which worked out. And I was able to attend some trainings that are current on food safety as well as restaurant grading, which was very interesting, which we'll cover a little bit. Hungry Coyote, as you know, I just want to give that quick update. We were able to take that information back to Francisco about having a consultant come every month, and he was in full agreement to do that. So we went ahead and extended a 6-month permit, and then we'll continue to get those monthly reports till the end of December. Needham Housing, we had a meeting with, we basically had a list of ongoing housing items. Tim, myself, Ally, met with the director and the assistant director, as well as the admin and the maintenance staff, and it was very productive. We felt it was a very good meeting where we caught up on some things. We laid out some protocols going forward when we get complaints. So we feel really good about moving forward. Actually, we've enacted some of the items that we addressed. Ally can tell you a little bit about that, but it's been working so far. So I think that was a good thing to pull everyone in the loop as far as what their expectations are, what our expectations are, and how we can work together, to help remediate a lot of those ongoing items. The farmers market opened on June 12th. So I went out with Ecom and we went through, kind of showed them the ropes on how to look at the vendors, what food safety items to watch out for. And he's been doing that now weekly for us on Sundays. So that's been working out great. So we'll have him continue to do that. The last one I wanted to update is on domain 6 for division accreditation, like Lynn had mentioned. So I have my environmental team assisting in that domain 6, which is the laws and policy. Enforce public health laws is the actual name of domain 6. So we're currently assessing all our current policies. We're putting everything in an Excel sheet, basically listing off what existing policies we have, where they're at as far as being reviewed annually, and also coming up with additional policies that we might need to put together for the environmental team. So we're working on that.
Yes, and then we have 2 kind of hot ticket items that we wanted to put on your radar. So one of them, we've been seeking to implement some sort of food grading. We've been thinking about it for a long time. But after doing a lot of research and kind of reaching out to surrounding towns, we've come up with another idea, which is a similar idea, but a certificate of excellence program. So we're currently working on a toolkit. We hope to establish parameters where we can go in, and if someone has a really good inspection report, we can provide them with a certificate of excellence. And then from there, we hope to really do a big community outreach piece where we educate Needham residents on what that means and what that is. Maybe we publicize these restaurants who have received a certificate of excellence online. And so we hope to incentivize restaurants and almost maybe bring out their competitive edge to really step up their game for food safety, and also tie in residents as well. So we wanted to see kind of what your opinion is on this, whether you think this would be a good fit for Needham, if you have any questions. Obviously, we can provide you with more information at a different meeting, but we wanted to kind of just mention it. So
I had a question about if you did ratings, does that always put, if you serve sushi, you're automatically in the higher risk category? Is it more about, it's not about the foods you serve?
it's more about
your
your inspection report, how you're doing. So if we go into a food safety, a routine food safety inspection, and someone does really well, and they meet the parameters of what we would consider excellent, we'll provide them with their certificate. They can put it in their window. But say we go back 6 months later and things go downhill, then it would be kind of removed from them. So that's kind of the idea there.
But it would certainly be easier to achieve an excellence if you were a gas station with soda.
Yeah, and okay, yes,
Yeah, exactly.
yes.
everything's
part of
already.
it is, who's eligible. Other towns have done something like this already.
Yes.
Is there interest amongst restaurants in participating in such a program? Because it just doesn't seem like this would drive people to the restaurant necessarily.
So we're still working on the toolkit, and that's something that we're gonna have to work on and see which restaurants or restaurants' opinion. But I think our idea was going away from ABC, because the feedback that we've received from that is that, especially Massachusetts, there's no, if it was statewide, then that would be useful. But if someone gets a C in Needham, but then you go the town over and no one else has food grading, it kind of makes it irrelevant. The other feedback that we received from like Boston, I think they do food grading. They said that their inspectors are getting badgered. Come back, I want an A, I want an A. And it's a lot of extra work on the inspector, and then not always as accurate, because then if they just fix the violations and you're going back right away and they get an A, it's a snapshot. So we think that restaurants would be more inclined towards this, and that they can boast it as well, that, oh, we are, the gold standard in Needham for food safety.
Rewarding the good ones versus, yeah.
Mhm.
Sorry, Denise.
Yeah, I just wanted to add to that, for Boston, I know they do their grades and it's almost like a pay for an A, because if you have a failing grade, you can pay a consultant, come in, fix everything, then you get your A and just go back to where you were before.
It's not that I don't want to encourage this, but to some degree, food safety, it's not,
It's not a
like,
prize.
well, one, it's not a prize, but it's like, in my business, it's like being a little bit pregnant. You either are or you aren't. The food is either safe or it isn't safe, right? And there's no in between here. So if a C grade means that it's safe, it's safe. If a C grade means it's not safe, then we should be shutting it down. And we've done this sort of thing. So I'm just not sure if the differentiation here of giving somebody a certificate of excellence as opposed to the one next door that doesn't, but we're saying that they're both perfectly safe to eat in, right?
That was my question or concern for the public, like because if the public sees these, would they think, oh, unless you have excellence, maybe you're not good, which isn't necessarily what we're saying. So I think, thinking about how, if we went with something like this, you'd have to really make sure people understand what that means. And to Steve's point, I do worry that, then people might interpret it as, oh, unless you have that certificate of excellence, I should meet there. So I think it's just something to think about.
It has to have a really strong public
We would,
education.
right, so be
Yeah.
part of it.
I guess one of the things that struck me about the Rice Barn situation is, Kathleen, you said a number of your friends are like, oh yeah, I stopped going in there years ago. So there was a period of time where we had it open, had some concerns about it, and some portion of the town population was like, oh yeah, avoid that place like the plague. Because it smelled like sewage, or they had noticed a drop in cleanliness. And I guess we're hoping that one of the outcomes could be better understanding, better attention to restaurant cleanliness and safe operations. Whether this is, exactly the right way, and some of the sort of pitfalls you mentioned, I think are things we have to explore. But I think the idea is just to try to have people be more aware of whether their restaurant is barely passing or exceeding expectations. I think your point about if they're not passing, then they need to be closed, I think it is potentially a good one, and maybe we have to have a higher or a quicker trigger on that too.
And I'm not sure we want to have another situation like we've had with the Rice Barn, but this is just dragged out, for months. Should be a way of, we should probably be doing things faster.
Yeah, well, we learned. I mean, we had Hungry Coyote, we've had Rice Barn. I think we
Right.
learned.
Yeah, and this will help incentivize, we're hoping, that's our goal, to incentivize these restaurants to really want to be proactive when we come in and do our routine inspections, because you're going to get the certificate now. And then the other piece that I wanted to add is that some states have now had this online, and some of the same risk restaurants will be ranked against each other. So it's almost does turn into a competition type thing, like one wants to get better than the other. So it makes them be more proactive on getting the items done prior to our inspectors showing up, instead of us writing out a lot of the violations and being reactive. which is what we see a lot of in town. And so it's our goal to have them be more proactive. And this is a way, a slant that we could use to have them.
So I wonder if you might model it on, what's the one for the seafood, HACCP, is that it? I forget what the acronym is.
Pass up.
But, you know, obviously some have it, some don't, but it's an important designation. People recognize it, you know, realize what that's worth. Maybe that would be something to kind of model this on.
Okay, and I think the other idea too is as a consumer, like if you wanted to go to a sushi restaurant and one of them had a certificate of excellence and one didn't, you were gonna get, you know, the same sushi roll, you know, which one would you choose? I actually think I'd want to go to the one that I know is safe and I know is clean. So that's also where we want to tie in.
Yeah, I'm leery about
residents.
sushi anyway, so.
But we just wanted to bring it up and get your opinions on it before we, you know, move forward and obviously, you know, can continue this discussion. Another interesting item, which is, this is kind of a new and emerging food trend, is micro markets. I'm not sure if you're familiar with them, but basically there is a technology where someone can open a store and have no one there. And there's cameras and they can go and get a snack and scan it. So I actually had someone reach out to me that they wanted to do this type of model. And I just kind of said, this is something that we have to actually work on, kind of a regulation or bring to our Board of Health. And I did not give her a definitive answer because it's very interesting and I think it's pretty nuanced.
Is this like Lean Box? That's what we have. We've had one in my company for like the last 4 years in Newton.
So
It's like a refrigerator and you swipe.
It's a little more it's a little more involved. So this person who reached out to me, they wanted to make salad sandwiches off-site, bring them on-site packaged. And then they also wanted open soup, which we would not approve of open food unattended. So it kind of raised some red flags. And it's something that we might want to get ahead of the curve. If we have a lot more people wanting to do these sorts of things, what would our regulation be? I know there is some guidance already out there, but I just wanted to also bring this up as
Sounds like a giant vending machine.
It does.
Sounds like,
Yeah, well, it's,
to me.
yeah.
Lean Box has salads.
Yeah.
and
It's
veggies.
like the ones at the airport, that it's open, because Lean Box is a vending machine, and that's regulated by the state anyway. Whereas this would just be like an open kiosk, like it's different, it was just chips, candy, prepackaged items, like I've seen that at the airport. That doesn't even require a food permit, because if it's a prepackaged shelf-stable item, you don't need a food permit. But if they're doing salad sandwiches, then that's more of a concern of who's coming.
Right.
Because we've had this before, that someone wanted to do it in a room, that it was like a room like this where an employee had a tag so they knew who was coming in. So they could kind of keep track if someone was taking food out of there, but we were concerned because it's, who's gonna check if the sandwich has been sitting here for 4 days, like. who's
Well,
checking
and not to
expiration
be
date?
alarmist, but who's also going to check and make sure the food's not tampered with?
Well, yeah. that was
Yeah,
the other
it's safe.
concern.
I thought about that.
And
But I think
there
they
are
could
gonna,
have the clamshells, like for the sandwiches, so you can see the tampering in the salad. I think that's where they would go with that, to protect the
Some type of
veggies,
tamper-proof,
but we would definitely be concerned with expiration dates and all that.
And what about like cold holding?
refrigeration, yeah. if
Like
you're-
who's gonna watch the unit if it starts getting warm and this whole thing just doesn't sit well right now with us. We gotta research that.
yeah, I wouldn't want to reject it out of hand, but I think it needs a lot of research and it probably its own set of regulations, independent of anything else.
Yeah, kind of ties in with Bill's Kitchen a little bit, like new topics that are. So moving on, we've been working on the standard 6 policy, incorporating a flow chart in all of your edits. We finished up animal permits. And we did have a foodborne illness case. It was one case of salmonella recorded on Maven. I did do a follow-up and there was no chicken on the salad. That was kind of a concern, but I did find decent amount of violations. One was a cold holding violation where the chicken was held. Again, there wasn't chicken on the salad, but still a concern that could cause an outbreak. So we worked with them diligently to make sure that they got that serviced appropriately and fix all of their violations as well. I think that's everything.
Can I just ask about the, and this is just something to raise, I pulled up our biotech, like we did then, there's gonna be many more of those. Regulations pretty out of date, like in terms of referencing NIH guidance from the 90s or something. So it's something to think about, like Cambridge's regulation is pretty simple, but they also require IBC, like a review committee and things like that. So I'd like to sort of get that on the table, just because there's gonna be a lot of labs coming out.
I think, yeah, with that potential development of the Muzzy property and other things that are going on, we should probably look at this.
And some of these smaller, that's the ones I think about too, you know, like less eyes on it too, some small startups and things.
Okay.
Thank you.
Shared services, Diana.
Report, pretty quick. So starting off, thank you for everyone who voted. We finally voted on a logo. I'm still waiting for the graphic designer to get back to me. We're gonna add the names of the 3 towns in the coalition to the bottom just to make it more distinct, because I think, or not I think, one of the Board of Health members in Medfield had made the suggestion because she thought seeing Charles River Public Health District is a little bit too generic. So just so we can have a better, or people can understand where that logo is coming from, and, you know, calling out Needham, Medfield, and Dover. As far as staffing, we hired Jessica Kent, who was on the accreditation team prior to coming onto our team. So she started on July 5th and now is in the process of doing all the intro trainings for to become an environmental health agent. So speaking of training, I went to the APTO Annual Education Conference in Phoenix in June, which was very informative. Allie was there too with me. Another training that we did, so I invited Jess before she started working officially as a health agent to join a virtual training about pre-rental housing regulations, and it was based in Western Mass. So it was interesting to see, not that we do pre-housing inspections right now, but I think it was good exposure for Roland and Jess to kind of see what other municipalities are doing and kind of introduce them to the housing code and some requirements of that. Roland completed a Food Code Pro refresher training with Diane Legere from Relevant Systems. And he also did an online comprehensive retail food inspection training with Diane. So Diane sent out kind of scenarios ahead of time. So it was like, if you go into this restaurant and points out different things, he kind of had to point out where the violations were in there. So that's what they did in June. And under the grant, I hired Mike Injiri, who is the septic agent in Dover. He's contracted there as well, but he agreed to help us. So he's helping the whole environmental health team get some septic training under their belts, because Needham, we only get maybe 5 or 6 plans a year. Dover gets 5 or 6 plans a month. So he's very well versed in plan reviews and doing the field work. So I'm happy that he was able to help us. So I was able to use some funds to get him to help Roland. So far, he's only gone out with Roland, or Roland went out with him in Dover to witness a perk test. And whenever Mike gets plans, he lets us know, or Needham gets plans, Tara and Allie can let me know so we can coordinate that he can go over and red mark all those plans. Because even though I've been in Needham for 5 years, like I said, we don't get very many plans. So I'm glad we have someone who's very experienced teaching our team all the ins and outs of septic, because I still feel like I'm not even close to being an expert, very nuanced. So very happy to have him. The contact tracers are continuing to contact trace. They're helping mostly Medfield and Dover right now. Needham, I think our team is pretty stacked, like they don't need to help. We're Brian and Needham, but they're doing Medfield and Dover. In Medfield, they've gone to just texting people now. They used to do 2 phone calls a day to the same people just to make sure that they get instructions. Now they leave a voicemail and we'll text them the instructions for isolation guidance and information like that. And then my other project was the purple air sensors. We set up, or I was able to get 2 more air sensors set up at Bowling College. And if you click that link, you'll be able to see the live feed, which is great.
Yeah, I was actually looking at that, and I think we, if we distribute them, and I don't know if we have enough to distribute.
So I have 5 more to go. So it'll be on next month's report for July. I just put one up last week at RRC. The difficulty with the sensor is finding a place that has not only power, but a reliable Wi-Fi signal. So where I set it up right outside the door of RRC, it almost like the signal almost didn't reach it for Wi-Fi. Like I was struggling a little bit to connect it just because it's outside and they have to go outside. So I know the middle school, they still have 1 sensor. They haven't been able to set it up because in the locations that we identified, the Wi-Fi signal was not strong enough to reach it. So we're still struggling with that piece. I think the state realized after they were distributed that it's not super easy. Like in theory, it sounds so simple. Like it's such a little device and it's so, it looks so easy. You just plug it in, connect it and go. But to find power and Wi-Fi has been a
I was
lot
gonna say,
more.
having a couple closer to the highway, I mean, we were worried about the Madera project,
Right,
right?
right.
For instance, right now, all of our sensors are from the center of town or away
Yeah.
from 128.
Yeah.
And they want to get some more towards.
Yeah, I mean, I could
128.
reach
Background
out.
site
That's a
and
great
the
idea.
senior center was the
Right.
one, I wanted to catch
Yes.
a train, I
Yep.
wanted to catch it, yeah, so I think we're working.
Yeah.
So,
No, I'll do a walk of CAF, the senior center, to see where, because I like at RSC, we only have the 1 outdoor outlet that was accessible for me, because I didn't want to go down by the pool where everyone might like start touching
Yeah.
things. At least ours is kind of hiding on the side of the entrance. You don't see it immediately when you walk up. But I'll look around because I wanted to do one at town hall too, but now they were doing the revitalization outside, so I didn't think it was a
Not
smart
a good
idea.
idea.
All the trees, I was by there this morning, so, my goodness.
not
Yeah.
random, yeah. not
So I didn't think that was a good
background
idea, but Kath, I'll walk around next week and see if there's.
Kath has Wi-Fi, doesn't have air conditioning, it has Wi-Fi.
Okay. And I actually bought like some sticker, or they're like adhesives that I can stick it onto the wall, because that was another thing, was figuring out how to attach it, because I wasn't allowed to drill a hole in the siding. So I found like an adhesive that I would, it's almost like a command strip, but it's stronger. It's like an extreme command strip. And it holds up to 12 pounds. These things are less than a pound. So I was able to stick it on the back of the sensor and stick it to the wall.
Yeah.
It says it's indoor, outdoor. So hopefully when it rains, it should be fine. I mean, it rained yesterday and it's still up today, so.
Yeah, maybe replace it.
Yeah, if it falls,
or something.
yeah, and we'll notice that if I look at the sensors, if it goes offline, but they're supposed to be up for about a year.
And they're not in a place where they fall on a person.
Say that again?
It's not in a place where it can fall on a person.
No, not at all.
Because that was another concern.
No, it's on the side, like, you know, at, when people come down for the pool, they walk down the hill where they're not supposed to. It's not gonna fall on anyone there, like, it's right at the landing, but it's also like a little bit above my eye level, and I'm 5 foot tall, I'm not that tall. I don't think it's gonna hurt anybody. So it should be okay. Yeah, we got 5 out of 5, or 5 out of 10 so far, so I just need to figure out 5 more locations.
One was intended as a background site.
Yeah.
right, And the other, Owen College was, friendly receptor.
Yeah. So,
Okay,
cool, thank you.
okay, thank you. Substance abuse prevention, Karen.
Yeah, good evening, everyone. I'd actually like to start before my updates to introduce you to one of my team on the prevention team. This is Jasmine Hurley. Jasmine has been with us almost a year, and she has been primarily focused on our Stop Act grant, although she's become acquainted with a number of our coalition activities and has been helpful there. And Jasmine's about to start her 2nd year at Boston College at the MSW program. So I was grateful that she could come and join a meeting tonight, and lo and behold, it's in person, so all the better. In terms of June, I'll just give a couple of real quick recaps. Speaking of the Stop Act grant, we had TIPS training conducted in last month in June by Carol Reed and Officer Jay Sullivan of the Dedham Police Department. We had 10 people attend the training, and this is our 2nd TIPS this year. We plan another one later this year. We're really pleased to be working with the police in getting both the alcohol compliance checks and the tips training sort of in tandem in a cycle where we can have it repeated, hopefully every 3 to 4 months. And we're looking forward to being able to sustain that. Just as a side note of the alcohol compliance check that was done in April, you may or may not recall, there were 5 sales to minor violations. And last month, the select board had a public hearing for one of those sales to minor violations. I don't know if anybody else happened to view that or attend that meeting, but one of our restaurants had a 3rd violation in a certain period of time. And the follow-up from that is most recently, they were issued a 3-day suspension of their alcohol license on non-consecutive days to be completed in 2022. And we certainly hope that we will not see them in another, we hope that there won't be another failure from them, but
3 non-consecutive Wednesdays is not exactly.
Not exactly funny.
yeah. And it was contingent on them not only having all of their servers tips certified within a 2-week period following that hearing, but also installing a license scanner device for all identification cards. So they did manage to do that. So they avoided a 4th day of suspension because of that. So it's a 3-day.
Was it retail or?
It was a restaurant.
It was a restaurant.
Yes. So our SALSA students ended the year up at the high school with 1,460 hours of service, which is incredible. It's an 8% increase over last year. And all of that service was conducted by 93 students. So not only have they increased their service hours, but the membership to this club, which is Students Advocating Life Without Substance Abuse, has really gained momentum. And we are really proud of that group of students. We are pleased to have some new quantitative data for our substance use prevention work. Both the 2021 Metro West Adolescent Health Survey was released internally through the school department. We were able to obtain copies of those reports, and we appreciate that because it helps tremendously in the planning we're doing this summer for our coalition. And then our parent survey, which is our survey instrument, was released this spring, and we are just now receiving the survey results for that. So both of those sets of data, which we like to have in tandem, will be really helpful to our work. And we'll be planning a presentation of that data to the community later in the fall. So we'll keep you posted. And then just kind of wrapping up here, I was able to attend a 3-day virtual training to be certified as a trainer in teen mental health first aid. Previous to this, I've been training youth mental health first aid, which is geared for adults learning the signs in young people. This training will be with the intention of training teens in the signs, the signs, early signs of mental health conditions among their peers, and primarily being able to help their peers connect to a trusted adult and somebody who can connect them to help and resources. So I'm one of 5 Health and Human Services staff who will be completing that training, and we hope to be offering that program at the high school in this upcoming school year. And then lastly, our staff spent a lot of time in June attending the various amounts of professional development training. So it's been a great opportunity to really catch up on a lot of prevention related trends and updates. Thank you.
All right, thank you. Anybody have any comments? Very good. Okay, we have Hannah and Mary nursing.
Yes, hello. So school year ended in June, and the following Monday, school camp started. So we immediately kind of pivoted into summer camp inspections. and licensure. And I believe it's primarily HANA. I believe we've got 5 camps have been licensed by the end of June, and we've since picked up at least a few more. HANA and I continue doing our standard blood pressure screenings, the last few piecemeal COVID-19 vaccines. The turnover for the flu vaccine this year also included me upside down in the ultra pool. And then my pet project, I'm ready to pitch to the board. So I've attached to our communicable disease report the new version that I'll be using starting next month. I've taken a lot of input from both Maven cases and Julie's amazing insight to try to figure out exactly what sort of things we're actually seeing in Needham, what hasn't been reported on in the past report, and how to sort of contour this to issues that, even if we haven't seen it in the last couple of years, historically are communicable diseases that we do have to come up in the town. I've already got a couple of working changes. So most of the way down the page, instead of just TB infection, I'm going to add latent to that. So really draw the distinction in between active tuberculosis disease and people just tested positive. But that's been completely left off the report up till now. So, we have upwards of 20 people in Needham every year who get a TB diagnosis, even if it's just LTBI. On average, 10% of people with an LTBI do eventually, if untreated, develop TB disease. And so this is, it's not a non-zero number, which the previous report gave a lot of indications that it was. Any other input anybody had on this, things that you think don't need to be included or that were previously included that you would like to see again, even if they were, most of what I removed was all zeros, going back 10 years. But this is the pitch, and I've already filled in the previous fiscal year's numbers going forward.
One suggestion to try, and I don't know if I'm making any clear. This is terrific. So consider grouping them by foodborne, respiratory, tick-borne. It might make it a little bit easier for us just to see, we've got kind of a cluster of this type of thing going on.
Yeah. This is the order that they show up on the Maven report, so it's easier to piece it in. My other plan was to, once we actually have numbers, fill it in on this, highlight what has actually got numbers on it in any given month. So just at a glance, you can see with a color change what we've actually had rather than having to go through piecemeal and find numbers. But yeah, I can absolutely play with the grouping too and find the way that's the easiest for you to read.
I think the latent TB is a really interesting one. Have you seen like some of that with post-COVID? People, it's sort of taking off.
So that was a question that I actually had at the National Tuberculosis Controllers Conference that I went to in Palm Springs. And there's a lot of research being done on how post-COVID is higher numbers of, or people with COVID tend to be more prone to tuberculosis disease as opposed to just LTBI. And they do not have numbers on that yet. But just like everything else that we're seeing as a kick up with post-COVID, shingles, I had 2 shingles cases this month. So everything else we're seeing is a slight kick from post-COVID. They are anecdotally and starting to get their research in motion to show that they're expecting an uptick too with TB.
We haven't even seen testing go back to healthcare workers. I haven't been tested in several years because there was a shortage of the tuberculosis.
It also is like an issue with follow-up, and you end up having people on continuous cycle, right? Kind of testing.
And it's not actually recommended. The TB skin test isn't routinely recommended anymore.
Yeah, the state has told us not to even do it. If we're concerned, just call them and they'll come run a blood test instead. Or send them to a clinic.
Right, it was like an antigen test or something. And again, antigen.
Right.
Okay, interesting. Thank you.
Okay, and now we're on to COVID update.
Okay, well, first off, it's my first in-person meeting, so it's nice to see everybody in person. But it makes a difference. So I first wanted to note that the state did announce that starting July 11th, they made a bunch of changes to their data reporting I think the one that people noted the most was that they are uploading data to that interactive dashboard once a week on Thursdays. So they're not going to be continuously updating some of the data on a daily basis as they had been. They did make a bunch of other sort of changes where they added or modified things in their dashboard report, and they modified some of the data in the vaccination report. And that is actually going to impact some of the numbers that we will see in the future on this chart, because some of the vaccination rates are now going to drop, because actually the denominators are a little bit closer to what the actual populations are. They did note in one of the state calls that the census data won't really be incorporated, and I think it's spring 2023, because there was some random noise in the census data, so it's going to take a bit. And I would just expect that in the next year or so, the data will maybe fluctuate, and it isn't because of any necessarily a trend, but it may be just denominators changing. And on that note of the state changing data, I think as we go through this presentation, I'm going through it with a very critical eye, so that going forward, we can figure out what data actually works best to keep talking about, and what data has sort of fallen off the wagon as sort of irrelevant with all of the at-home testing, and which data can and can't be used as indicators for us going forward, or is there something else that we'd like to be focusing on? So I guess sort of knowing that, the incidence rates and the percent positivities, I think we can still sort of look at the upward and downward trends, but obviously they miss out on all of those at-home tests. But over the past few weeks, I haven't really seen any changes in a lot of our numbers. We're kind of in this weird stagnant period right now. Looking at the NEDM in the next slide, again, we've kind of been hovering around 5 cases as our 7-day average. Again, this doesn't include any of the at-home tests. I think this becomes a really challenging thing now, because at-home tests were becoming the preferred option, but now I think they're no longer hard to come by at all. In fact, NEDM is really encouraging people to come and pick up the boxes and boxes of tests that we have. And people are starting to really understand when they can take an at-home test for it to be most effective. I think there's been some good guidance on that. And, there's starting to become sort of public knowledge that PCR isn't necessarily the best option, because you can test positive by PCR up to 3 months after being infected. So with more people having had COVID recently, I think people are avoiding PCR tests, which may be a false positive. And those people are not necessarily infectious, and the virus can't be cultured from them. So knowing this, that we have to be skeptical, we can still sort of look at our numbers in the next couple of slides, and that, June, we had 225 official cases, and the average age was about 42, and we had a lot more cases in the 40 to 49 and 50 to 59-year-olds. And this was the July cases I captured were the very, very beginning of July, but up to July 15th, I looked today, and we're at 87 cases. And so if this trend for the first half of July does hold for the second half of July, we would be looking at less cases compared to June. If we go to the next slide, the vaccination rates, again, this data is going to look pretty different the next time I show it, because of the denominator changes, which I'm happy about, because it will give us actually more accurate numbers. But the nice thing is we're starting to see the 0 to 4-year-old data come up. I think the newest report that's come out, we're at 29% have had their first dose. The big changes that they made to the vaccination report, they're now breaking down by 1 dose, fully vaccinated, individuals who had their first booster, and individuals who had their second booster. So in the next reports, I'll be able to break that down even further, which is nice. One sort of thing to keep in mind is that for the kids, the Pfizer is a 3-dose series and the Moderna is a 2-dose series, the 0 to 4-year-olds. I'm not really sure if that will cause some issues for them in terms of reporting. I'm hoping those kids will they'll go from at least 1 dose to fully vaccinated, but I'm skeptical that there won't be some issues there with Pfizer being a 3-dose series, but we'll keep an eye on it. But it's nice to see those numbers come in. So this is just an ever-changing situation. And since I put this up, BA.5 has very quickly become the dominant variant. It's now about 77% of our cases, which is very different from this picture. Data from South Africa doesn't seem to indicate that BA.5 is more severe than the previous Omicron variant, but as with all of the variants, it is quite contagious. So there are rises in cases that are being associated with these new BA.4 and BA.5 variants. We may see that here because it seems like booster doses and prior infection aren't necessarily protective against you being infected with BA.5, but it is protective against more severe disease, which is good. But I do think we, again, being skeptical and being critical of the data, need to note that the rise in cases may cause rises in other things like hospitalizations, which is important to note, but it doesn't necessarily mean that the rise in hospitalizations means the disease is more severe. Next slide. So the cases have just sort of been sitting at the same level, a little bit of fluctuation up and down in the state. I didn't show the wastewater this time around either because I didn't see a lot of change in that data either. And, you know, to add a little bit of criticism to that data as well, I think that it can be a good indicator of trends and where the data is going. But because that data can't be broken down on a town by town basis, and we can't actually get it on even a Norfolk County basis, we do have to be critical because we're clumped into that South system data, which covers a lot of different areas. I think it's also going to be interesting to monitor that going forward because the wastewater data does rely on the fact that COVID is shed in the feces. With Omicron, it seems to be shed less in the feces. And as the variants continue, we'll have to see how wastewater continues to be, an accurate predictor of trends going forward. The hospitalization rates, I think, we can look at the hospitalization rates as indicators of where things are, of how many people are in the hospital, obviously of how inundated the hospitals may be. But I do think, we have to be very critical of the fact that, we look at this and the hospitalization rates are much higher than they were a year ago, which does tell us something. But again, we have to look at it under the eye that Omicron is very contagious. All of the variants have been very contagious. So it's causing more cases. Thus, even when the disease is less severe, more cases means more hospitalizations. And also more people who are going into the hospital are going to test positive upon admission. And I think, I was talking with Mary and Tiffany
the
recently.
state divides that out, right?
It does, yeah.
When you're looking at this, is this primary diagnosis of COVID or is this secondary?
This is everything together. And so
Okay.
this next one is the one we definitely should look at, yeah.
Yeah.
But I think in addition, in a discussion yesterday, we were talking about sort of what we had been mentioning, these other impacts of COVID. People had been putting off healthcare for a very long time. People have unmanaged chronic diseases. They weren't going for cancer screenings. And I think there are more people in the hospital. There are more people who are now seeking the help they need, or unfortunately their conditions have caused them to go to the hospital. So I do think that there are more people at the hospital, unfortunately, and those people are probably also testing positive for COVID because it's infectious, they may be asymptomatic. Just sort of something to keep in mind. And I think something we may want to think about talking about more in the scheme of COVID, not necessarily just COVID itself, but those other things that we really need to start keeping an eye on, the long-term impacts of COVID. That's my hypercritical eye of the data, and just trying to get us to really think about what it is that we want to look at in the future that would or would not be a good indicator of, warning signs.
Primary hospitalizations, yes. Population adjusted cases, we still need to keep track of. Percent positivity is less useful now, unfortunately. I mean, I think a lot of people have been saying wastewater is probably the best we have, and I agree. It's not great for hyper local stuff like what we want to do here. But you can't play with the numbers by having everybody do home tests.
I think the case rates is the same issue with the test positivity too, right? So they're becoming less useful. I
Yeah,
think the with
that's true.
hospitalized with COVID is probably just the one that makes sense. I actually think the wastewater too, but like you said, trend wise
Yeah.
is a good indicator. But yeah, you can't, it's also the wastewater used to all the regions, you know, in Massachusetts, the north and south would track closely. And we're seeing less of that, even when it's, but when you look at the BioBot data, look at the regions or county data, there's more variability because these pockets of people who never had COVID are getting it. And so the spread is different than when it's just hitting the urban areas and more densely populated, sort of my view. But, so I think, yeah, we could save you time. The question is, do we keep our dashboard up? Do we, you know, the data is continuing to be released on it. It's only updated once a week, but they are providing daily data retroactively. I don't know.
So my recommendation on that would be yes, until the state removes theirs, only because at some point, so Dr. Brown explained in our meeting a while back that the national planning is in transition slowly from COVID focused surveillance to respiratory illness in general. And so that's what the talk is going on nationally. And so at some point they will transition as well to a respiratory illness type process that we could as well.
Yeah.
Yeah, remember there was a hue and cry over not releasing all of the data for people to take a look at.
Right, I remember.
Yeah,
and then
but
again,
But in terms of, you know, what I think, I mean, I think we've pretty much told you what to keep front and center, right? So, you know, the hospitalizations are the ones we really care about.
Yeah.
You know, the wastewater is great for trends. What was the third? Vaccination rates is something else I think we do need to, you know, kind of keep track
I
of
think
as
you need to
well,
keep
because
track of
that gives us some sort of indication of the likelihood of severe disease in our population.
I think the other thing, the state data is, it's probably just a privacy thing. They never break down hospitals. I want to know and need them by age group. So, or the hospitalization, yeah, you can do either by age group or other demographics. Oh, that's it. The with COVID or with, it's only total hospitalizations by age group. What I want to know is of the ones who were in for COVID, what are those age? I'm sure it's all people whose boosters have waned, right? I mean, not all, but obviously statistically heavily weighted to the over 75.
Yeah, and obviously the hospital here doesn't admit pediatrics, so you know, depending on if I don't know if the data are by, you know, if anybody who's admitted to BI Needham is considered like a needed admission, as opposed to, you know, our kids who lined up at Wellesley or Children's, whether they count as needed in terms of hospitalization.
So we don't have hospitalization rates broken down that much by town. We can look at by hospital.
Right.
Yeah.
So just, you know, just bear in mind that, you know, for Needham, you know, it's really 18 and over. I mean, there's the rare, you know, 16-year-old that they'll operate on or something like that, but it's really 18 and over.
Okay.
I just have one thing to add to, just while we're talking respiratory illness, just to note that the Southern Hemisphere is seeing their flu about 8 weeks earlier than anticipated. And so what that means for us, we can't really do much unless the CDC and the state changes the flu season time when we can give it out. But we are having a webinar at the beginning of August to learn a little bit more. So just know that that may increase sooner than expected.
Okay.
Sorry, Tejal had asked if the board wanted to have a discussion about what sort of COVID numbers we need to pay attention to inform some of the planning for the fall. And I know that we talked a little bit about what data you want to see in future presentations. Tejal, I didn't know if you wanted to say what you were specifically looking for, or if you wanted to start that conversation.
No, I think this conversation was really helpful because I think knowing what measures we really want to be tracking is really the starting point, so that if we start to see worrisome trends and hospitalizations, things like that, then, you know, kind of knowing that's our key measures that we're going to be looking at. But yeah, I mean, the question I had was, I mean, I wasn't on the Board of Health 2.5 years ago, but, you know, what are the things that would make us really start to worry? And, you know, I was thinking about this only because I've been hearing that, you know, LA County is starting to think about mask mandates. Other places are starting to think about it. I certainly, you know, have no desire to have to think about that, but I feel like we should at least, you know, know when the trends are looking in a certain direction that we have to start having those conversations. So that was really what sparked that question to you, Tim, on that other call.
I mean, part of it obviously depends on the lethality or morbidity and mortality of the virus. You know, the initial strain obviously caused a tremendous amount of morbidity and mortality. Omicron, tremendously less. Not that it doesn't, but tremendously less. And I think that informs some of it. Because in the past, they would say, 2.5%, test positivity rate in the community. That's when you start going with mask mandates. That doesn't make any sense anymore, right? I mean, we're up at 5% right now. There's no mask mandate. We're kind of hovering there. We're not seeing it take off in terms of hospitalization. So we have to kind of rethink some of that.
Totally agree. And I think following our vaccination rates is really helpful as well. And I'm actually glad that they're going to start distinguishing first booster and second booster and all of that, which will be really helpful. And we are seeing pockets around the country where I think their positivity rates are really going up, where they are actually trying to think about mandates. I'm hoping we never get to that, especially given our high vaccination rates. So just, I think the conversation around what measures we think are most critical was what we need at this point.
Okay, excellent. The senior survey, that's the next thing on the agenda. We're running a little behind.
Sure. So I think Lynn did cover that pretty well in her monthly report. I don't know if there's other questions the board had.
I had just one question, and it doesn't relate to this survey because the survey is already out. But I did notice, in my day job, we've created some best practices around asking about gender, sexual identity, race, ethnicity, et cetera, that having done a lot of research on how to best ask those things. And I saw that the survey had a different approach. So I was just thinking offline, I'd be happy to share kind of the way we've been recommending that hospitals and health systems at least ask about those things, if that would be helpful.
That'd be great. Tasha, I'll connect with you and we can talk to Lynn. Scott.
Okay. All right, we're up to other items. Tim, do you want to?
Sure, there were a couple other items briefly for the board's attention. Most are for your information. There's a 50-year COVID Community Water Fluoridation Award, which not many communities got. 6 communities total in Massachusetts. Obviously, Needham is a community that has long fluoridated water. This is just a recognition of that. There's the notice, which is an annual notice from the Department of Environmental Protection to the boards of health throughout the state about water quality. Water quality is, a particular issue. I think some of the board members might have been following Wellesley and their challenges with PFAS in their water supply. It has had excellent reports in its water. Nice to know that. This has since actually exacerbated. I don't know what last night's thunderstorms may have done, if anything, to modify it just a little bit, but the state is in drought status. One of the things that we certainly want to be aware of, and it's something that the board may want to consider weighing in sort of as a policy matter to other boards, is how does the town work to conserve water? What is the sort of public health implication of being in drought status? And then I did include the select board adopted a remote participation in public meeting policy. They adopted it in time for then the state legislature to act over the weekend to make a new state law that basically renders it moot for at least the next 7 or 8 months. State policy is an extension of what was in place previously, which allows remote only or hybrid meetings so long as public access and where public participation is maintained. The select board policy is more limited, more constricting. In essence, it says you can have a meeting as long as a quorum of the board is physically present. The chair, or if the chair has designated someone else to lead the meeting, is notified of any member that is going to be missing. That no member missed more than 25% of total meetings. So it is more restrictive, but if the state legislation lapses again, which often happens, the legislature doesn't get around to acting in time and then acts a little bit later, the select board policy would hold. So not something that needs to be worried about for at least 8 months. think those were everything.
Okay, so I know we had discussion the other night, and someone wanted to just have the food inspection policy that's being developed discussed at one of our meetings in the future.
Definitely, and I do wonder if the board would like to have, historically, the board has usually had a combined July and August meeting. Given the question about discounts and CIRA, is that something the board would like to have a specific August meeting to move that event to a conclusion, or would you rather meet again in September?
I think we can continue our tradition unless there's a serious call for a meeting. Like, for example, if we have a hearing on appeal.
Riceburn.
Yeah, Riceburn.
How long has this year thing? When did it start? Last November?
It's
Yeah,
it's
October.
been going-
It's been going on
Yeah.
for a while.
Yeah, they need an answer.
I mean,
I would like
Some
to
of
get,
this-
I mean, I would like to get some of that. I mean, this is, I asked, the last time we met with them, I forget if that was last month, I think it was 2 months ago. Right after that was when I started asking about, the differential. And, it's taken a couple of meetings to get that response. So hopefully we can get some information from the other boards a little bit more quickly and, kind of see what's going on in the communities around us.
You should be able to.
If they did a meeting early in September, then maybe that would work.
Sure. And if, as essentially might be expected, Mr. Inta decides to challenge or appeal the board's decision in front of the board, would the board be open for that meeting, including, presumably we've got the answers to the Sierra question as well? So if we do have to convene, would you like to add a little bit more onto the agenda or just deal with the appeal?
We have the information and we can look at it ahead of time.
Yeah.
We do,
Right,
but,
on the other
but
board.
that hearing is going to be very quick, right?
10 days.
Because he has only a certain number of days and then we have.
He
a
has to
certain-
appeal within 10 days, and then the board has to allow his hearing within 10 days of getting his notification. Or the board can proactively set a date for an appeal if you would want. So you could set a date, and it would have to be at least 10 days from when he gets the letter, which would be tomorrow. If you could set a date for later this month, very end of this month, or the beginning of August, if you wanted to.
The problem is that we're going to be very busy at the beginning of August.
Yeah, I'm out of town the first week of August.
Let's look at this appeal, I guess. It
Well,
doesn't watch
if
this
you
meeting.
remote, I mean, I could do it remote.
Well, let's see what happens. But how we can convene if we have to.
So would it be appropriate to do a doodle poll just so we have that data available?
Yeah, all right.
Probably a good idea.
Good idea.
The only thing I'd add for, upcoming, I guess, is, although it's really more relevant now is cooling, cooling stations. I mean, we're in the middle of a heat wave. I don't know if we need them. But if we do, I know we have plans, but it's like, what are the criteria for opening?
Oh, we already, planning to open one tomorrow. Opening is soft because we only have 2 to 3 people come at max total. So we are blasting out, just waiting for the YMCA to hear back. We're going to blast out buildings that will be open that they can go to that is cooling and have things. So we'll include the RRC, the library is open till 9 every day through Thursday, and hopefully the YMCA.
Yeah. But, let's take this British heat wave as an opportunity, perhaps, if we're talking about water, to also talk about, heat related illness and what we need to do proactively in the future for the town.
The town right now is dealing with a number of buildings that have either significant challenges or have failing AC systems. That all relates to sort of international supply chain shortages. But right now, for example, there's a number of portable ACs that are installed at the center of the Heights, which are sort of struggling to keep the temperature in the mid-70s. And RRC is better, but is not functioning at 100% capacity. So it's unfortunate. It does mean we have to be a little bit more creative potentially if there is a sustained heat wave this week.
Yeah, police offered their community room, but we'd have to staff it, so that's the difficulty part of this one.
I just wanted to bring up one thing. I got a call from, I think, an editor at the Boston Globe today, wanting to know if I wanted to participate in, they have a column where they ask a question And then there's a pro and con letter.
Oh, yeah.
And the thing, the one they were interested in is for us, for me, would be to talk, the question is to promote a tax on junk food. And then what they would want would be a pro for that, looking at all the bad things that junk foods do to you and good nutrition and why that, how that could possibly encourage good nutrition and so on. And I just said, and for health reasons, and I said, basically, that's out of my comfort zone. And I didn't know that much about it, that I could do that in the Globe. So I was just wondering if anybody here knew someone or wanted to do that or participate in it. I could then call the editor, I got his number, and give him your information.
They're asking you to be pro tax.
Yeah.
Yeah.
I
New
wonder
York
if Alan
tried
Stern would be
something.
interested, actually.
Tried sugary drinks. Yeah,
Yeah,
sugar
Alan
tax.
Stern might be. He
I mean, it
very
adversely
much,
impacts the people. who are
Yeah,
trying to-
I might reach out to Alan. I mean, it's a pediatrician
At
in
least
his
people
role
can
at
look
school
at it.
and
I
a
don't
previous
know.
Board of Health member.
Yeah, that'd be good.
Because that.
I thought of
his
Alan.
population for the most part.
That'd be great if you would reach out to him. And then if you got back to me, if he says yes, then I would like to
I'll confirm to you
have
the
him-
details.
have him get to me.
Okay.
Sure, great. Okay. Any other business? All right. Motion to adjourn.
Yeah, we have to do it by roll call.
What?
We have to do it by roll.
I
call.
know, yeah. Motion to adjourn.
So moved.
Steve, okay, second. Okay, motion to adjourn. Steve Epstein,
Yes.
Kathleen,
Yes.
Tajal,
Yes.
and Cosgrove, yes. We're adjourned.
Thank you.
Right on time.
2 minutes